Thanks. Thank you. Don't know if can you...
Yep, there you go.
Thanks. Certainly not pointing, but I do have a question for Megan, and it was just around the telemast intervention and the latch memory intervention programs. What sort of cost is associated with those programs?
As far as I understand, these are the trials that we are running at the moment, so it's free of charge to anyone who is interested in participating in this study. I think in return, you might have to complete some questionnaires so that we just have data to see whether that's effective or not.
Great, thank you.
G'day. For the palliative care, you said if you live right on a boundary, you might end up being directed to some place, but you've done all your treatment at another equidistant location. Is it possible to go outside?
The short answer is no, but the long answer is sometimes there's a bit of movement. The way that the community palliative care teams work, so that means people who potentially come to your home or do telehealth, and therefore the way the occupational therapists who might set up things, that is all depending on where you live, because it's then the community palliative care teams who work as a team. The little bit of wiggle room is sometimes that there will be outpatient palliative care clinics and there will be palliative care specialists that will be based in the hospital. So to give you an example, here at North Shore, I work here at Royal North Shore Hospital. I see any patients who come in here to Royal North Shore Hospital, whether they live in our area health service or not. We have outpatient clinics. So again, I can see patients who come from non-local health district areas. The issue would be if you were needing care at home and linked to the community palliative care team. Unfortunately, there's no wiggle room with that, just because it needs to be someone who can physically go out to your home, so they need to be based in that area health service.
So just on that, Bridget, because I know that it comes up. So if you live in an area health service out of the Northern Sydney Area Health, you've had all your treatment here at North Shore, you've developed the relationships, there is still, and you can correct me if I'm wrong, but say you needed, as you said, the community stuff needs to be from that local community team, but if you chose to then go, you needed to go into a hospice, you could actually go in as a private patient from another area health service in to whichever particular service you wish to. Is that correct?
So again, the short answer is yes, but the long answer is it's a bit more complicated. If someone in area, so if that palliative care unit was full and had patients that were in area, then they theoretically would take a higher priority just because that's how it works. But often what we do, if someone has a relationship, if they have a relationship with a specialist who's at the nearby hospital, then sometimes it'd be case by case. And so I would see a patient who was in area here at North Shore, and if I thought they were most appropriately served by being at, say, so in our area health service, we've got Greenwich, Naringa, Mona Vale palliative care units, and if I thought that someone was best served because they had the relationship, they were closer to their specialist, or because they had family members who lived nearby here, which again is a very reasonable reason, therefore, to come here as opposed to somewhere that maybe is away for family members, I would pick up the phone and speak to the palliative care specialist at the local palliative care unit and say, can we talk this through? Because this person actually has real needs to come to this unit. So,
yeah, and just on that further, so if you were in a different health service and you got seen by a palliative care consultant in that area, how then do you get, if you choose to be in a hospice in, say, this area, how does that process happen?
So that would then also usually happen with that person, the palliative care specialist that you see there, speaking here. So that might happen if, for example, then you had issues and you were linked to your community palliative care team, and say, for example, we say it's in Western Sydney just because our two local health districts sort of are adjacent to one another. That palliative care then specialist could ring up the palliative care unit here and say, actually, I've got someone who would be better served, I feel, being in your unit for A, B and C reasons. Can we get them on the list?
I think it's really important that you really need the services within your community, because they're the nurses, the specialist nurses, the palliative care nurses, occupational therapists, physiotherapists, social workers that are able to visit you and support you at home. So seeing those initially, I think, is really, really important. So anything else there to add, Anne-Marie?
So it was in my mind, now it's gone out of it. Just to your point there, Rena, if you're linked in with local community services, they should be communicating with your treatment area, so even if it's different, but also when you need care, you need it in a timely manner. Mm-hmm. So if you in a way, you kind of disadvantage yourself if you try and get community from another area, because you might have to wait, and actually there just probably isn't capacity for that crossover, which seems ridiculous, but it's the system, and we, work within it the best way we can. But yeah, I think it's all about communication between different service providers, and the onus of that should not be on the patient and family, but often it does fall to you.
We got any other questions? Okay. One thing that I will ask, because we haven't spoken very much, I suppose it's been pretty focused on the high-grade glioma or glioblastoma, a little bit around the lower grade, maybe grade 2, 3, just the support around that and the watch and wait protocol, or thoughts, and how long do you wait before you get treatment? I think, that's around communication again. And just a second to that, any molecular testing, I guess, that can be done on the tumour to identify mutations and how that sort of happens. And so, when have you got anything?
So I think with the lower grade gliomas, it really is that multidisciplinary approach as to whether you watch and wait, when you re-resect, when you start radiotherapy and systemic therapy. I think across the board, once it becomes more difficult, you're exhausting your standard treatments, then we start thinking about doing that molecular profiling. In terms of what we tend to find, we do know that most of the low-grade gliomas will have things like IDH mutations. It's one of the key hallmarks of that type of low-grade glioma. And so I guess if we have drugs that can target that, that's something promising. I think in general terms, lower-grade gliomas tend to be simpler tumours. There may be some key targets. So I think increasingly, if there's access to profiling, we're keen for most people at some point in time to be able to see what molecular characteristics are part of that tumour.
Okay.
And that could be done, you can pay for that funding privately. The cost is increasingly getting less over time as technology improves. We also have a molecular screening program called MOST at the moment, where when we're starting to run out of standard treatment options, that could be funded through that trial platform at this point.
Okay. Did you want to make any comments on that, Dr. Back?
Just with a surveillance program or observation in patients who are yet to have radiotherapy and chemo, once again, when you're looking at MRIs, you look over the sequence of time, but also you're looking at if there's any development of symptoms or what's threatening. So you might be able to have a 10 millimeters growth, 15 millimeters growth in one area of the brain, and you may not need to act on that. But if it's right next to the motor strip, where the left arm and left leg may be affected, then you don't want to let that get 10 millimeters or more. So you have to pick the geographical areas of the brain. I guess part of what we're realizing is that brain tumors are not just one condition. There's multiple sites in the brain, and each one of them has got their own different characteristics and their own treatment directions.
Thank you. Okay, yeah.
Well, you might have sort of... Is it all right? Yeah. Maybe you've partly answered this already, but I'm kind of wondering, when is the best time to have a crack at a novel treatment, or, and what's the best way to access it?
So I think it's not well defined. At the moment, in terms of standard practice, I think unless we find something striking, which is rare, like a BRAF or NTRK, in most cases we will be using the standard options, surgery, radiation and systemic therapy first, and then clinical trials will often be when we've run out of those standard options. But that paradigm may be changing. For example, some of the trials are now trying to position things at an earlier phase. That trial I mentioned with that IDH inhibitor is actually positioned in the setting where you haven't had radiotherapy or chemotherapy yet, so in that sort of watch and wait phase. The idea of that trial was whether IDH inhibitors could delay the need for these additional treatments, and we're told potentially it may prolong that timing, so there may be some use there. So trials really haven't defined that space, but I think we're going to see in the upcoming years trials starting to try to look at that sequencing. The other area of interest has been whether some of these treatments given before surgery, particularly immune therapy, may have a role. We know that the process of surgery, the process of radiotherapy, and temozolomide being a lymphopenic drug may suppress the immune response. And so perhaps it's important to get the immune therapy in first before these other treatments. So people are starting to explore these ideas. I think standard practice at the moment is still to give the standard stoop and those type of treatments first, but we may be seeing a change in that fairly soon.
And I think just historically as well, a lot of the trials, if you hadn't had radiation and chemotherapy in the first protocol as such, that you weren't going to be eligible anyway.
That's right. So I think historically we've been quite lazy with our eligibility. We've just gone, once you've exhausted standard options, now you're eligible for trials. I think we're trying to be more flexible, trying to look for opportunities that we may have missed in the past. So I think we're trying to learn as much as possible per trial. We've had so many unsuccessful trials where we've probably wasted some of these chances.
While we're on the trials thing, I haven't actually heard of this one, but there was an online question asking about a new hydrogel used in mice gliomas. Have you heard?
I'm not familiar with that one myself.
I haven't heard this either. Okay. Just going a little bit more for you, Megan, I just wanted to ask in regard to psychologists and their approach to the uncertainty or recurrence and how psychologists deal with that. Is it more around cognitive behavioural therapy? What actually occurs when psychologists see patients to discuss this sort of thing?
Well, when it comes to individual therapy with individual patients or caregivers, it will be based on the history and the problems or the issues that are sort of imminent or more, prominent for that person. So it will be really different individually, but if the fear of cancer recurrence is the issue or the anxiety is the issue, that's actually uncertainty. Is the anxiety. It's a type of anxiety, and this can, the gold standard treatment for that will be cognitive behavior therapy, but evidence is suggesting maybe this ACT therapy, which is sort of looking at more how we can help people with accepting the diagnosis and sort of looking at changes in the life and how we can sort of adapt to that change. That has been also showing some positive effects on the quality of life and the mood and functioning in general. So yeah, it will depend on individual patients, but there are many sort of options to target. And I guess what we are trying to do on the BRAINS program is sort of targeting the aspects of uncertainty that is not knowing, sort of in the middle of dark area, waiting and not having much control over the care decisions and everything else. So what we saw as very important is to actually identifying those who are in need of further information or further support and provide what support they are in need of at that time of tumor journey. So that's what we are sort of looking at doing, so developing screening measures and sort of connecting them to their healthcare providers so that they can get the support when it's needed the most.
Because that is a big issue for patients with primary brain tumours is the anxiety, and obviously it's around the diagnosis each time you have an MRI and that uncertainty time. So it sort of does come in ebbs and flows and can get, you know, more difficult to manage at different times as well, along with all the medications we put people on, you know, make them stay awake and things like that. So, yeah, it's important. Actually, staying on that, something that I'll bring up, there was a question around what carers can do to better support their loved ones through surgery and treatment, and also questions about material written for children to explain what's going on. There's some really good information on the Cancer Council website that's been, you know, reviewed quite regularly, and that can be accessed freely. There are quite a few I've seen with sort of the UK groups and American groups. They also put out things, also something to speak to clinical psychologists about. They'll give a lot of advice about how to speak to children about changes, fatigue levels, mood changes, you know, those sorts of things, and, you know, the end of life support care stuff as well. All right. Another question around ketogenic diet. How, when? Sorry.
The idea of a ketogenic diet has been known for a while. I guess the idea is that brain tumor cells, if you deprive them of a glucose supply, hopefully they can't grow as rapidly, but the body can use ketone bodies instead as an alternative fuel source. So ketogenic diet tries to exploit that by being very low in glucose. I think that the data about whether that has brain tumor modifying effects, I think that works very well, definitely in a preclinical model. Whether that translates into a patient is less clear to us. And I guess one of the things is that we potentially may be underestimating how clever the tumor cells may be. And I think there's some conflicting data that sometimes we think the brain tumor cells may also have adaptive metabolic pathways that they can use. It may not be that clear cut. I think when patients ask about ketogenic diet, for me, as long as I guess diet, one of the risks is that if you become too restrictive with your diet, you may actually be worse off. So I think the priority is that people are still eating a good balanced diet and getting the necessary caloric intake. If they want to try restricting certain things, I don't have a huge problem with that as long as they are maintaining those key aspects of the diet. I don't think we have enough data to say that it doesn't work or does work definitively.
Yeah. Anything to mention on that? No. Okay. Any other questions?
Just to follow up to that.
Yep. We'll just get you a microphone. Hang on. We'll just grab a microphone.
Sorry, just a follow-up to that one. Are there any studies that you are aware of, or anyone's aware of, or planned studies in that respect for dietary adjunctive treatments and that sort of stuff?
I'm not aware of any upcoming trials specifically on diet in the brain cancer setting. Yeah, not specifically. I mean, there have been some ideas about sort of folate and a few other things like that we're working up as early concepts, but nothing that's really reached the trial design that I'm aware of.
Okay. There's a few questions that are coming through online, again about relapse or recurrent anaplastic meningioma, but I think we answered that question this morning. So maybe, because this will all be as a recording online that people can access, won't it, Dennis? Yes, it will be. Yeah, so maybe you can go back and review the information that was given out this morning, because there was quite extensive stuff about meningioma recurrence this morning. Another comment online was a lady mentioned for kids, Mummy's Wish is an Australian group which they found helpful. So I actually haven't heard of that one, so I'll have a look at that one, and we can put it online as well, just as an extra resource. Do you have in palliative care specific stuff that for talking to kids? Because obviously a lot of our patients, you know, have got adolescent kids, younger kids, teenage kids. It's hard.
Yes, so there are a number of resources that we use, and it very much depends on the family, the children, the age. So that's something we actually do offer families, is the opportunity to talk about how they talk to their children. And then depending on that, we have different resources and different places we can link them into. Yeah, so it's always worth bringing that up with your palliative care team, and we can. Derek's Place is an organisation that Hammond have partnered with, so they provide resources for children who are spending time with a sick parent in hospital.
Yeah, that's a great resource, that one. Yeah.
I didn't have much else to add. The only other thing is Canteen, which I'm sure lots of people have heard of, but they do also have some just remarkable programs at being able to help kids at an age-appropriate stage, particularly teenagers. So we often refer people there as well.
Because it is life-changing for kids, you know, so it's just being mindful of how these kids grow into adults and what affects them in adulthood.
And can I just make one comment on that? I think often parents believe that saying nothing, we're protecting our children, but actually children know something's going on, so it's actually much more beneficial to have those conversations with them.
Okay. And I've just been told that Bear Cottage also have a sibling program, because it's, obviously if you've got we do have some patients that are sort of that around that 18, 19, 20 mark, so massively affects, you know, the siblings as well. Okay, have we got any further questions? Okay, thank you very much, everybody. Thanks for coming today. It's been a really great day. I think it's been a really great subject to talk about. Even though it's around relapse or recurrence, it's an important thing to discuss. And we've had some fantastic speakers today. I really want to thank all the doctors who gave their time today in their busy clinics, and the clinicians. It's just been a really valuable session. And also to see the amount of people that we were able to see today and the amount that are online. As we said, this will be turned into a video by Dennis. Your videos are edited, so anything that I've said wrong, he'll chop out. And yeah, it'll be available online for you to go back and have a look at. Thanks very much for coming.